مساء الخير، أهلا وسهلا بكم في محاضرة هذا المساء، وهي بعنوان سكيزوفرينيا. يقدمها الأخ العزيز الدكتور محمد الحيحي، وهو مستشار في الطب النفسي في المملكة المتحدة، يعني مش إنجليزي، فلسطيني. وأرحب بمن انضم معنا من أطباء قطاع غزة. أهلا وسهلا بكم. تفضل دكتور.
شكرا دكتور وليد، وأتمنى الحقيقة أن أكون موفق في هذه المحاضرة. أهلا وسهلا في أهلنا في غزة والأطباء الأعزاء الموجودين معنا. سكيزوفرينيا طبعا زي ما بتعرفوا يعني the most important and serious mental disorder. We have the duty and responsibility to know. Definitely in this hour, I'm going to tell you about schizophrenia, but also at the same time, I would really recommend that you read about the subject. There are plenty of textbooks and papers published about schizophrenia. The Oxford textbook of psychiatry is very important, so you can read this subject. Schizophrenia, it's a Greek word, and it means split mind. A lot of myths about schizophrenia, about مرض الفصام. People sometimes believe that they have different personalities or more than one, or they have the ability to split between these. But the reality is not about this, really. Schizophrenia is a split of the mind. The functions of the mind, they become split. And that means they affect the thinking, the organized thoughts about life in general and around their surroundings is becoming disturbed. It's a serious psychotic disorder, and usually it's insidious, gradual kind of development of this illness. And there is a period which is very important. It's called untreated period of psychosis, where people, they become very ill for years, but they manage to hide their symptomatology and to function until specific kind of stressful event happened and they become very ill. With schizophrenia, there is a serious consequences of physical health, and sometimes they can create comorbidity, which really affects the whole quality of life of these individuals. And as you know, there are
السلايدز ما تحرك يا دكتور.
still 5-6% of these individuals, they are ending their life. We need to know as academics, as doctors, about the development in literature about schizophrenia. And since the 19th century, there were a lot of articles has been published about schizophrenia, and they used to call it unitary psychosis. They were unable to identify what are the differences between the symptomatology until Emil Kraepelin was interested to look carefully at these symptoms and try to make a classification. And as you may have heard, that there were two things really he described. One is called dementia precox, and the other one is manic depressive or depression, manic depression. Dementia precox, definitely he was referring to schizophrenia to make it, to differentiate between dementia, as we know. Precox means early, so, and because he noticed that these individuals, they are of young age comparing with the dementia in older age.
خدها هي معها حلوة لذيذة.
A bit later, Schneider in Germany, he identified first-rank symptoms, and he managed to put them in a group and to say, if any individual who has one or two or more of these symptoms, they have schizophrenia. And he identified these symptoms as hearing thoughts spoken aloud. The individual, their own thoughts, they hear them. Third person auditory hallucinations. So like, for example, the neighbors, they are talking about the individual who is in the other house, and they say he is doing something, or he is going to make a cake, for example. Commentary hallucinations, they hear voices making comments about what they do, what they behave, how they feel. And the somatic hallucinations, somatic hallucinations where the individual believe that they have specific things they are crawling, for example, over their skin. They feel it, sensations. Thought insertion, thoughts they are inserted in their brain or their mind, and also somebody has the ability to withdraw these kind of thoughts. And when people, they go out, they feel everyone knows about their thoughts, as if they can read their mind. These called thought broadcasting. Delusional perception is very pathognomonic of schizophrenia, and I hope you will pay more attention to this. Like, for example, somebody get out of the house in the morning and they see a red car or a red bus. That means for them, there will be blood in this day. Somebody will be killed or so. So they will try to justify their fear and their thoughts based on the perception that they have seen earlier. After Kraepelin came Eugene Bleuler. He called schizophrenia. He called the illness as schizophrenia, and he focused on as we said, about the splitting from different functions of the mind. And he introduced the four A's, the 4A, Bleuler, which is the blunted affect. So you can see the individual doesn't react really to sadness or happiness. They are blunted. The same thing with the loss of association. When their thoughts, they are not coherent, they are not logic. You can see that during their speech, they direct themselves into different areas of thinking without knowing that they have some problem there. The ambivalence, definitely this is very interesting, where you see the individual, they are unable to make a decision, and they are as if they are lost.
ألو مرحبا صلاحا.
And again, the A is the autism. One of the main criteria for schizophrenia was that in that particular time is the autistic features, which we have a different kind of category at the present time. After Bleuler, Freud, as you know, he is very the main founder of psychodynamics, and he was focused on the schizophrenia as a disturbance of the unconscious, العقل الباطني, caused by the unresolved feelings of homosexuality. This definitely, you need to know more about the theory of psychodynamics to understand his thoughts. And the same thing, he focused on, or he united schizophrenia with depression as people who have this kind of generalized unhappiness and sadness in life. They feel that they don't deserve to be in this quality of life because they have more than what the others they do. And these are the narcissistic kind of feelings that they have, and they deserve to die or to go from this society. To know about schizophrenia, definitely you need to know about the dopamine theory or the dopaminergic system. And this is from the anatomy point of view. When you look at the dopaminergic pathway, you can identify the mesolimbic pathway, which is responsible for the positive symptoms. And this definitely it will take you into the pharmacology, where the medication itself, where they work through the neurotransmitters into the brain. The mesocortical pathway responsible for the negative symptoms. And again, when people develop schizophrenia, you can see sometimes that these areas, they are disturbed at that extent that you can identify the symptomatology. But also when you intervene with neuroleptic medication, you may end up having side effects. Like in the nigrostriatal pathway, you can have the extrapyramidal side effect and tardive dyskinesia. As we know from the first generation of the antipsychotic medication fully responsible for that. And the tuberofindibular pathway, you can see the increase of prolactin blood level when you prescribe drugs like risperidone or olanzapine. The etiology for schizophrenia, this is a very controversial and very big subject, really. However, there have been a high number of studies on the genetic factors. As you know, like any other medical condition, genetic factors always comes first as etiology. The importance of schizophrenia that if you have monozygotic twins, you can see the incidence of schizophrenia is very high. If you have dizygotic twins, for example, you can find that the incidence is less than the monozygotic, and this can confirm the responsibility of the genetic factors. There have been some studies regarding Norway people, individuals, who some of them immigrated into United States, and some of them stayed in Norway, and they have been study around the difference between their quality of life. And they found that brothers and sisters of similar kind of family, they had the same illness while they are in different places. And that also confirmed the genetic responsibility for this illness. The pregnancy and the childbirth complications, there have been studies around this to confirm that there are some individuals might end up having schizophrenia during the difficult labor. And some, they might have infection during their labor, or the mom when she was conceived during a pregnancy, when she became pregnant. The environmental risk is very important also. A lot of studies about traumatic experiences during the study, where people can identify the symptoms. Winter birth, for example, they are more susceptible to have schizophrenia. And there have been also studies around the role of the mother in the development and the growing up of the children, as responsible schizophrenogenic mother can induce symptomatology of schizophrenia. Definitely the social functioning and schizophrenia also is very important when we talk about. You need to study the social functioning also since early childhood to understand the development of schizophrenia. People, when they live with this kind of illness, the majority of them, they are single or they live by themselves. They are unemployed. Their quality of life is very poor sometimes, and you can find that the social withdrawal is one of the major components. And these social functioning, a lot of psychologists, they might look at it as etiological factors, but some others, they might look at it as a consequences of the illness in itself. The social adjustment scale is a good thing to apply during your identification of an individual who is suffering of schizophrenia. And the same happening with the quality of life scale. We use here in every single individual, we see for an assessment of psychosis or schizophrenia, the HONOS scale, the health of the nation, quality of life, which is very short and very good scale introduced by the Royal College of Psychiatrists. The social functioning and clinical symptomatology, the link between the social, you can see the decline in their social functioning while they're becoming acutely psychotic. The premorbid social functioning and development problem, it's also very important during the assessment of schizophrenia. Regarding the incidence of schizophrenia, this is again an area which differs from one country to another. The prevalence is affected usually by traumatic experience like migration and mortality, the prevalence. The incidence is a critical variable where you can see how many in a year you can see people suffering of schizophrenia. So you can prepare yourself in advance regarding the staff who needs to deal with these individuals and the pharmacotherapy and the psychological treatment. The WHO have identified that in USA, you have 1.6 per 10,000 in USA, around 2.8 million adults aged 18 and older, they are suffering of schizophrenia. If you compare this number to in India, you can see 4.2, which is more. In Nottingham, in UK, it's 1.4. So there is a differences between the incidence of schizophrenia in different countries. 61.6% of schizophrenic patients, they are men, and 47.4% of women who are developed the first schizophrenic episode before the age of 25. This is important. Why? Because if you look at the numbers, you can see more younger people in men develop schizophrenia compared with women. And also with the advanced age, you can see the women and the men, they becoming about to be equal. And what that say really? That a number of men, they die because of the suicide of the illness, more than women. This is one of the slides that I have done a research many years ago, and I had 85 patients of schizophrenia who were in the study. And you can see the under the age of 25, they are the majority, and also 25 to 35 is coming less. But when you go up of age, the age at the first contact with mental health services is declining in schizophrenia. Oh, what happened? What's this going on? I have no idea how that happened. Again, in here in this slide is very important to strengthen the genetic factors related to schizophrenia. If you look at the general population in terms of incidence is 1%. In the first cousin, for example, is 2%. Uncles and aunties, they are 2%. Then if you are nieces, 4%. So it's increasing. Grandchildren, 5%. The half siblings is one of the parent is involved is 6%. The parents, if somebody has schizophrenia, their parents, they have 6% chance of developing schizophrenia. The siblings, around 10%. The children, around 15%. And the same, the fraternal twins, brother and sister or two brothers, 17%. The identical twins is 50%. So this confirms the theory of the genetic factors. And as we said, it's in men earlier than in women. What's that going to? Do you see these lines red in the slides? Strange. If we look at the nosology of the symptomatology, there are definitely in the last 2-3 decades have been a lot of studies, and they were controversial in terms of a duration. The duration of the symptomatology when you have the duty to identify and to confirm the diagnosis of schizophrenia. Why is that it's important? Because as I said previously, there is untreated period of psychosis. It's unlikely that if the disorder is coming insidious, gradual, sometimes they take years to end up seeking help or treatment for their illness. So the DSM-5 requires 2 or more of the following positive symptomatology for 1 month, which is the delusions, hallucinations, disorganized speech, catatonic behavior, formal thought disorder, and thought derailment. Thought derailment, it's like the railway. You are in the process of talking about what you think, and suddenly you drift into some other thoughts. That's thought derailment. The negative symptomatology, as you know, is the blunted affect, social withdrawal, anhedonia, no pleasure in life, loss of initiatives, and social withdrawal, definitely. All these kind of elements, they are negative symptoms. When we say negative, it means that these functions in the individual, they becoming less and less until it really is becoming dysfunctional in their quality of life. The schizoaffective disorder, and this is definitely you need to consider schizoaffective disorder is a part of schizophrenia. However, you can see the component of affective component in it. And this is the incidence is 0.3%. This is a mixture symptoms of, as we said, positive or negative and mood disorder. And there are some studies who can really easily identify them as type manic or type depression. However, I think schizoaffective disorder, it's recognized in clinical practice. Delusional disorder is 0.2% of the cases of schizophrenia. And you can see the whole aspects of the symptomatology are present, except the fact that the hallucinations or the auditory hallucinations, they are not too disturbing at that extent that we see it in schizophrenia. So, and they have a number of thoughts or delusions which are disturbing them. Yeah, it seems that I have a number of patients with delusional disorder. They function, most of them, except that these delusions, they are over preoccupied with them. The brief psychotic disorder, it's a situation where sudden psychotic episode happen, and within a couple of weeks, they are resolved completely and they recover. And they go back into their functioning. This is called brief psychotic disorder. Sometimes we call it also transient acute psychotic disorder. The schizophreniform disorder, it's a full picture of schizophrenia, but again, the duration is the issue around this. Because if it happened within a couple of weeks or 3 weeks and they are fine later on and they are happy and they back to their functioning, usually the individual themselves, they might challenge the diagnosis of schizophrenia, and they usually don't like it. Now the catatonia, it's a condition where the individual comes into A&E or the emergency room mute, and they don't move. It was common really previously. Nowadays, as the neuroleptic medication or the antipsychotics, they are more common to prescribe around the world. You can see it less as you have community services who can reach the individuals in their own home here in UK, and I honestly believe also in our countries. So the decreased response to others, they don't interact with others. It can occur quickly, sometimes within a couple of days, and it can happen at any age. But to be honest with you, it's more common with younger individuals. Definitely, you need to ensure that these individuals, they are safe and they don't harm themselves and others. Sorry. They can suddenly become excited with aggressive behavior. And when they are admitted, usually you will have 2 to 3 staffs to observe them on a regular basis. These are the symptoms of schizophrenia, of catatonia. Stuporous state is slowness of psychomotor activity, and they are mute, they don't eat, they don't drink, yeah, and their condition deteriorate. You can see the stupor in depression also. It's more common, in fact, in depression than in schizophrenia stupor. Rigidity within the catatonia, if you examine their limbs and their neck, you can see the rigidity. The fixed posture, you can see them standing near the window for hours, they don't move.
ليش بتستخدم الرصيد الرئيسي بالبطاقة؟
الميكروفونات لو سمحت.
فيها رصيد رئيسي.
Wax flexibility is when the individual, they stand and if you ask them to hold their hand up, for example, they continue doing that for hours without feeling tired, or they need to change their condition. Definitely they are tired by doing these kind of behavior. Not responding to instructions, stereotype movement or mannerism. You can see them going, coming back, going, coming back, going, coming back, and grimacing. Grimacing is the movements they do in their face to express, could be the anger or frustration, some emotional disturbance is there, but they don't pay attention to others, how they think about them. Repeating someone's word, if you ask them, how are you today? Oh, they keep saying, how are you? How are you today? How are you today? Yeah, copying someone's movement, again, the same thing. If you try to shake their hands, they keep putting their hand to shake. They may stop eating or drinking, and this is very important. This is one of the emergency we face in catatonia, where the people, they start to have critical medical condition because of this. Not sleeping at all, and this is really a situation where require active and quick intervention by giving them IV medication to help them to sleep. Poor personal care. Definitely they don't take care of their personal hygiene or bathing or changing clothes. But also the horrible thing here that they become incontinent. And definitely one of the things which you can, as a clinician, differentiate between incontinence in schizophrenia and incontinence in depression is if they are doubly incontinent, definitely you need to go through a schizophrenic illness. If they are incontinence of urine, for example, you might think that they are, and they have some other specific functions, could be of tuberous state of depression. This condition improves quickly after ECT. The first, second, third ECT, you can see marked improvement in their mental state, but the duration of this improvement also it's short. The duration of this, so you need to continue with a number of ECTs, 8 to 12, to ensure that they are recovering. They wake up, and the most important thing in catatonia that they recall every single event happened during their catatonic situations. So they will tell you what you were saying during word round, for example, about them. And they register that very nicely. As we said, negative symptoms, it's all the functions that every human being enjoy, but in individuals with schizophrenia, they are less and less and less. Yeah, reduced verbal output. They speak little, or they end up not speaking. Reduced facial emotional expression, like the blunted affect or flat affect. We see, like if you give them a good news or a happy news, they have no reaction. If you give them a sad news, it's the same. Reduced spontaneous movement. For example, if you are sitting with the family and you want to do a cup of coffee and they have no idea what they need to do, you can see that they are completely isolated in their own way. Poor eye contact, direct eye contact, you can see they are detached. And as we said, these behavioral issues about the stupor, waxy flexibility, catalepsy, and the catatonia, they are severe forms of behavioral disturbance. The mannerism, the automatic obedience, sometimes you can see it in catatonia or in severe retardation in schizophrenia. So you ask the patient, for example, take off your shoes and put it on the table. They do it, and there is no purpose of that. Yeah. The first episode of schizophrenia, first episode psychosis with negative symptoms has poor prognosis. When these negative symptoms appear earlier, in the course of the illness, the prognosis is bad. And also at the same time, you need to bear in mind during the course of the negative symptoms, you need to assess depression. So the symptoms, how the patient with schizophrenia, they come for help. It's a very interesting question, to be honest with you. And usually, why I'm saying this, because there are individuals who are very good to hide their symptomatology and they manage. Definitely their quality of life is not good, but they are intelligent enough to know, because they have partial insight, to know that they are mad. And what's the point of going to explore and to expose themselves to the doctors and the family? So they are delusional. But the problem is that they can't really face it for long when the parent or the family and the relatives and the neighbors, they notice odd, bizarre behavior happening. So they can interfere and seek help for this individual. Delusional, having paranoid persecutory delusions, for example, hallucinations, having auditory hallucinations is common. Their speech or their thoughts become disorganized. They might also talking about nihilistic kind of delusions. It's common in depression, but also it can have a component in schizophrenia. They might end up having retardation and catatonia, as we said, and the negative symptoms like the flat affect, the poverty of speech, volition, no interest to do anything, no purpose of doing it. And the decline in social functioning. For example, if they had any job before, they may start not going every day or going late or not interested to report to their managers what's happening. As we said about Schneider, first-rank symptoms of schizophrenia. The third person auditory hallucinations is very important, and you need to pay more attention to that because it's pathognomonic of schizophrenia. So if you want to ensure about the diagnosis, you can really investigate or ask the individual about the third person, hearing voices, others talking about them. So they are referring to them. Yeah. The thoughts spoken aloud, as we said, passivity phenomena, something happening and people go inside the house and they while they are in sleep, interfering with their body. This is passivity there. Thought insertion, putting thoughts in their mind. They have the power to take the thoughts away and they spread it, like the TV, spreading the information and the news about the individuals. Everyone knows about it. They go to the shop to buy something, and before they speak, the shopkeeper, they will tell them, oh, you are coming here to buy this. So already they know, broadcasting. Delusional perception, they see something, a red car. It means that the Russians, they are invading the country. This is very common, was in the Cold War. Yeah. Now, definitely one of the components of the assessment of schizophrenia is the mental state examination. And definitely you need to go to do the mental state examination. You can't really exclude anything. It's like the physical examination. Yeah. So the appearance and behavior, when you look at the individual, What I want to say really that schizophrenia, it's not a homogeneous group. Not all the individuals who are suffering of schizophrenia are the same. You need to study, yes, schizophrenia as a disorder, but also you need to know the individual. Yeah, so you might find differences between one schizophrenic and another. So the appearance and behavior, if they have specific period of time with schizophrenia, so there are the consequences of these delusional system or perception, it appears on them. So they might smile or laugh or giggling to themselves without no apparent reason. Yeah, they might appear to be irritable, frustrated when they attend the clinic. One thing I want really to draw your attention to it, I have seen some patients when they come with load of clothes on them. Oh, for example, the temperature is not that cold, but they wear a lot of clothes. And this is called disturbance in the thermoregulations. We know the hypothalamus have responsibility, have some functions in the brain on the thermoregulation. And these are due, it's actually controversial, the explanation for it, if it's the medication can cause that, or there is a dysfunction of the hypothalamus in itself. If you look at the speech during the mental state examination, that you might see that their representation reflect what they are thinking about. They are not there. You look at them and they are distant, detached. And their speech also can reflect what they are thinking at that particular moment. The mood, yeah, sometimes they are pleasant and they are friendly, but some other times you might find that they are angry, frustrated, unhappy, sometimes sad. As we said, the flat affect, you might see it. And sometimes you might see that they are indifferent in their emotions. Very interested when you see the ambivalence, that they can't make decisions or they can't say their thoughts. You can see the perplexed affect. محتار يعني. Congruent and incongruent affect, it's very important. So they talk about something, for example, and it's congruent, but their affect is different. Like you give them a happy news and they become crying or tearful or frustrated, and sad news and they laugh. Incongruent. Stream of thought, sometimes you find them, they are over preoccupied with their thinking. And you need to bear in mind that sometimes there are some neurotic conditions could be also added into the clinical presentation, like obsessional ruminations with schizophrenia. The night's moves, also it's a form of disturbance of the thought. Yeah. While they are talking, they give you some clues about something they are disturbed about or traumatic for them, but clues about it, not the whole thought. The hallucinations, they might describe, just let me say, very often we hear people coming to the clinic and complaining of hallucinations, hearing voices, and they describe it to you like stories. Yeah. You need to be careful about admitting or identifying these kind of claims, because the real hallucinations, they are very, very disturbing and usually described as noises. They hear the noise or music or single words, calling them their names. Very rarely you might find in schizophrenia that they talk about a complete sentence or, yeah. Sometimes they talk about their own thoughts spoken loudly, their own thoughts, and they are bizarre, odd. The primary delusional mood is very, very important as pathognomonic for schizophrenia also. So you have a delusion and they become affecting the mood in itself. They become a primary problem for them. The cognitive functions usually normal in the first years of developing schizophrenia. A bit later, you might find, due to the social dysfunction, that they are not aware of what the day is, what's the month, what's happening on the news. They are not interested because of lack of interest. There are some theories that there are cognitive decline due to the schizophrenic illness in itself, or maybe induced by the medication that we prescribe. The insight usually impaired. In paranoid schizophrenia, occasionally you may find that someone has partial insight. So they can manage to function, they go to work and they come back and they care for their families, but they have one or two kind of delusional system and they are convinced 100% that this is happening, and definitely nobody agrees with them. The chronic syndrome in schizophrenia also is, we need to pay more attention to it. It's rare, but it can happen that it comes as first signs of the illness. We used previously, many years ago, to talk about hypophrenia and simple schizophrenia or schizoid kind of personality things. But I think nowadays it's less than before due to the spread of the antipsychotic medication. However, usually they come as disheveled, unkempt after many years of developing the schizophrenia as acute symptoms. They spend most of their time alone in their own rooms, playing maybe on games, on computer. And they are usually underactive, no direct eye contact. The speech usually is little, unspontaneous, slow. They are not interested to make any conversation. And their interest of going out or meeting family or visiting, it's going in decline. The affect is blunted. And sometimes they might tell you odd ideas that belong, for example, to royal family or things like that. Threats to violence. Occasionally you can find these kind of symptomatology. And also their motor activity is becoming disturbed. Like we said before, the stupor state, excitement or aggression can happen suddenly sometimes, and that might require restraint or pharmacological restraint. Waxy flexibility, stereotype movements, and mannerism, the automatic obedience. Usually they are orientated to time, place, and person. And their insight, they are impaired into their mental health condition. The mental capacity, it's very, very important. I don't know how much you pay attention to this because of the legal aspects related to the illness in itself. Yeah, but usually you can test the mental capacity during the conversation with the individual. if they can retain the information, if they can register them, you ask them to repeat things or to recall some things happened, and their understanding of why they are with you, why they are coming to the clinic, and what they want. This is the mental capacity. Right. One of the aspects which really is very important in schizophrenia, as you know, is suicide. Yeah. As we said previously, 5 to 6% of individuals suffering of schizophrenia, they end up ending their life. And I'm sure our colleagues everywhere in the world have suffered this kind of problems, because it will affect not only the family of the individual, but also the clinicians and the people working with them. So the factors which really drives people into suicide: hopelessness status, when they feel there is no out of this. It's a dilemma. They live in this darkness. They are not, there is no resolution. Yeah. And they have little insight. This is why I said not always they have insight impaired. When they have the partial insight and they know they talk rubbish and they are mad, so they end up in status like that. Young age, schizophrenia affects a young age more than others. And when they suffer, and that might drive them into suicide. People who have schizophrenia and they drink alcohol. People who have schizophrenia and they don't have income, they are unemployed. Recent hospital discharge from the hospital, 2-3 weeks after discharge, they need to be followed up in the community to ensure that they have no thoughts of suicide, to revenge this kind of horrible life that they had during their hospital admission. If they had suicidal attempts previously, this put them at significant risk of suicide again. And if they suffered from fluid psychotic symptoms, as we said about the delusional system, some of them very bizarre and very odd at that extent that plenty of people criticize them, that might really create a reaction from them. If they don't take their prescribed medication, which is very, very common, especially if they are discharged on oral medication, there is a significant percentage of these individuals, they discontinue taking the medication. And if they have no support at home or in their surroundings, no one check on them, they might end up having no money to survive on it. When we assess schizophrenia, we need to look at the prognosis. And very often, people usually, if they are intellectual, if they are students, if they are qualified, they will ask you, what do you think, doctor, of me? How I can get better? What I need to do? So we look at we study the history, their life, to answer these questions. If the incident happened during their acute stages of the illness, insidious, the prognosis is bad. If it took too long, if there is untreated period of psychosis and they came too late, that the prognosis is bad. If they take illicit drugs, cannabis, amphetamine, MDMA, ketamine, and they drink too much alcohol, they misuse it, that could be also a predisposing factor to bad prognosis. If there is past psychiatric history, if they have been in touch previously about psychiatric manifestations, especially with anxiety, we need to bear in mind not always the anxiety when it manifests itself, it's part of anxiety disorders. Sometimes can be an early manifestations of schizophrenia or psychosis. If there is a history of violence and you can see the individual, they are unable to justify that kind of event, that put them at bad prognosis. The long duration of the first illness, if they have been attended A&E following aggressive behavior, and they have been admitted to hospital, and they stayed there instead of staying 4-6 weeks, they stayed 3 months or 4 months, that's long. Emotional blunting during the acute stage, that also indicate bad prognosis. The social withdrawal during the illness, that indicate poor social, psychosocial functioning and a bad prognosis. The depressive symptoms associated with suicide in schizophrenia, as we identified, feeling guilty. You know, when young people, very often we see young people going to university, and during the course of their first year, they become acutely psychotic and they attend the clinics. Definitely, when they realize that their parents, their dad have spent a lot of money going from Palestine to America, and they have put them down, really, they feel guilty. And that's strong feelings to lead to take them into suicide. The pathological guilt, what we talk about, yeah. When they are slow in their psychomotor activity, loss of interest in their functions, they are not interested to go back into work or to show emotional aspects of life. And if they admit that they have suicidal thoughts, the positive symptoms of schizophrenia, which might lead into suicide, this is important also, the thoughts. I think as junior doctors, you need to pay a lot of attention into the mechanism of these symptomatology, the thought control, thought insertion, and broadcasting. Spend more time with the individual. How is that happening? Try to engage with them in discussion about the effect of these symptoms. The lose of association. They talk, but you can see this connection between the sentences. When they hear voices telling them to kill themselves, yeah, command hallucinations. The lack of insight into their, so that means that they are not complying. There is no compliance or adherence to the management plan, including not taking medication. What are the warning signs in patient at risk of suicide and they have schizophrenia? They stop talking. It's common. They don't talk to, even to the people who were close to them. Like the daughter doesn't talk to her mom. Yeah. Or a young man doesn't talk to his friends. The depressive symptoms and the hopelessness, as we said. If there is a history in the individual of traumatic exposure, This is very interesting. For example, refugees, immigrants, and they have traumatic experience, some of it unresolved, and they develop acute psychotic episode. You need to bear in mind about the risk of suicide. Akathisia, if you prescribe haloperidol, if you prescribe risperidone, and also aripiprazole, akathisia is common. And you can see the agitation, restlessness in them. And sometimes they go to sleep. And I hear that very often from patients that they have akathisia during, they got restless legs, they can't sleep because of that. You need to give them benzodiazepine for a while and reduce the dose. And you can maybe augment the medication with something else. They are troubled with the command hallucinations. They tell you, I'm worried about these voices. They keep coming to me. Yeah. I don't know what Dr. Sarhan thinks, but is there anybody can answer the question from the, what percentage of patients with schizophrenia complete?
تفضلوا شباب. كانت في السلايد الأول.
If no volunteer, yeah.
تفضلي جنان. دكتورة جنان.
6%.
Right. Yeah. That's C.
Mhm.
5 to 10%, because it can be 6% in America, might be less in UK, might be more in India or in Africa. Yeah, but definitely it's C. You are right. (20 to 40% of patients with schizophrenia attempt suicide. 5 to 10% commit suicide. Definitely is more in men, and the average life expectancy decreased by 20% comparing with the general population. So this is important also because you need to bear in mind not only the illness as schizophrenia, but also how we prescribe medication for them and what they do to their body. 20% of all hospital bed occupancy in UK, which is a lot really, a lot of expenses. Patients with schizophrenia have increased risk of medical comorbidity and unhealthy lifestyle. And regarding this sentence only, we can spend an hour talking about this. Oh, sorry. I think I missed that. Young age of onset, male gender, schizophrenia, and long duration of the illness, all these kind of elements make patients, they are at risk really. The prominent features in our patients with schizophrenia, they becoming poor prognosis. There is a gradual increase in the incidence of schizophrenia. The limited number of hospital beds require new development of comprehensive community services for the young, severely ill patient. As Dr. Walid knows, I work for the first episode psychosis, or we call it PATH, which is assessment and treatment and in the community, early intervention. And we have comprehensive team who works with each individual who has been identified as first episode psychosis. accurate identification of individuals in the earliest symptomatic stages of psychosis, offers more effective treatment strategies. Another question, Dr. Walid. What percentage of your schizophrenic patients suffer from comorbidity such as diabetes, hypertension, cardiovascular disease, or hyperlipidemia?
أبي
Any,
سهل.
yeah,
شو رأيك؟
any volunteer? If not, I will tell you.
Wallahi, Doctor, I think it is D. More than half of them.
Right. You are good.
Thank you.
Mhm.
Yeah. It's around 75% actually. It's high, yeah. And this is why, as doctors, we need to pay more attention also to the physical health. In fact, now in UK, we have responsibility to ensure that their physical health have been checked annually. And also there are specific kind of tests needs to be done. The nurses in the mini team, what we call them, they check their vital signs when they come to the clinic. And people on clozapine and lithium, they have special attention, and valproate also. So the answer is D. This is part of the study that I have done. I had a number of patients and I studied all of them with schizophrenia. And you can see the history. I'm not sure. Yeah, the history, these factors with schizophrenia, symptomatology, you can see their illegal drug abuse. The majority had suicide, around 25 out of 80 something had suicidal attempts, forensic history, alcohol misuse, and illegal drug use. The factors which predispose to bad, I think we have said this, insidious, yeah. Neurological soft signs, I might have repeated that, but if you look at the development of the child and you study them carefully, you may find some disturbances in their neurological kind of development. Like you hear a lot about clumsy walking. That's a neurological soft sign. You might hear about grimacing or movement disorder or disturbance. Yeah. A lot of symptoms now, they are part of ADHD, they might say, and some also about ASD. However, I think it's very important to check the developmental history in childhood. Past psychiatric history, history of violence, long duration of affairs, emotional planting, and social withdrawal. Yeah. Dr. Walid, before I finish, I would like to say this story about, I don't know how many of you they know about a band, music band called Pink Floyd. I'm sure Dr. SARHAN knows. And they have an album called Wish You Were Here. I don't know if you know about Roger Waters. He is very, very interesting activist. He has been to the UN around 2 months ago talking about Palestine. and he has one of his latest album called Waiting for Her انتظرها لمحمود درويش قصيدة محمود درويش غناها. بس why I'm talking about this, because of this man, Sid Barrett. He was a guitar player, and also he has written these words. And he was very close to Roger Waters. Pink Floyd, they are from the 70s. Now they have a lot of differences between the members of the group, so they are separated. Roger Waters, he's not working with them now because he pays a lot of time to Palestine. And you can, if you Google his name, you can see plenty of things, and he has been in conferences. But Sid Barrett, he had schizophrenia. That's what I want to say. And during his work with the group, he was on neuroleptic injections, and he put on weight. And at one stage, I think in the early 90s, he withdrew from the group, and he was at home. He had a wife and children. And one day, he took an overdose and he killed himself. So what he says, which is a lovely song, and you love it if you look at the YouTube, listen to it, as if he talks about Gaza. So you think you can tell heaven from hell, blue skies from pain. Can you tell a green field from a cold steel rail, a smile from a veil? Do you think you can tell? How I wish you were here. We are just two lost souls swimming in a fishbowl, year after year, running over the old same green ground. What have we found? The same old fears. Wish you were here. Thank you, Dr. Walid.
شكرا جزيلا على هذا العرض الرائع، والحقيقة عرض وافي في زمن قصير، ونترك المجال لأي سؤال من الحاضرين. تعليقات، استفسارات. أنا عندي استفسار. What do you think the next 20 years in schizophrenia, how it's going to develop?
Right. I think this is a very important question. And I honestly believe, based on the history, so the next 20 years, I need to look back at maybe 200 years to answer the question. I think the psychopharmacology have developed greatly in terms of introducing new medication, and we are now having the new generation of antipsychotic. But also they had a lot of metabolic problems. From time to time, we hear about new medication, less effect on the metabolic kind of consequences. But there is a hope that the psychopharmacology industry will come with a new medication. But what really Dr. Walid helped, I remember when I came here, it was the institutions and the big hospitals where patients, they used to live there and work. And so they were some kind of a community happened for them in that particular time. But then suddenly they started to demolish these big hospitals and build new houses, and they took the patients into the community. And the patients, they started to live as part of the any kind of community sector. There were a lot of positive things, but also there were some negative aspects happened in terms of these people. They were unable to adjust back into the community, and some of them really had lived a disastrous life, including suicide. So this is the situation. But in the next 20 years, I believe we need more community work and more psychological intervention to get the situation better. There are plenty of things needs to be done. You know, the cost is one of the major aspects of care. And we need to find the funding for these kind of interventions. So I hope that the injections that we are prescribing now, as you know, paliperidone, Trevicta, for example, you give one injection every 3 months. Yeah, and this is the positive kind of thing. When I see the individuals who prescribe oral medication like paliperidone or risperidone, I say, well, look, if we'll give the injection monthly for 6 months, then we can switch to Trevicta, so you will have 4 injections in a year. And that's a positive thing.
And now there is the one every 6 months available.
Right. We haven't heard about it in UK, but I'm sure we will. Yeah. So it's not a bad area that we need to do more research about it and to understand the situation better. I'm not sure how is it in Jordan or in Palestine at the present time. I know they depend on oral medication. Yeah.
في عنا سؤال بالنسبة للمراهقين، كيف نفرق بين أعراض ثنائي القطب وفرط الحركة؟
Right. You see, the ADHD, it's an area which is becoming a fashion nowadays, and especially in countries like UK and the West. Plenty of people, they come to the clinic, they say, oh, my child has been diagnosed with ADHD. And when I look at what they do, the same as I used to do myself. So I have ADHD. Yeah. Bipolar affective disorder, it's also a history in itself, really. It's well identified. And the psychiatrists, they know the clinical picture quite clearly. So I don't think there is a problem in the diagnosis. But the symptomatology that you are referring to between the two, I don't think it's difficult to know what is the difference between inattention or impulsivity and behavioral disturbance and the symptomatology of bipolar affective disorder. So clinically, I don't think it's difficult to know the difference between the symptoms. Yeah. Am I answering the question right, or there are specific things?
Yes, that's all. في عنا الدكتورة جنان والدكتورة صفية. تفضلي دكتورة جنان. كتبت السؤال.
أي نعم كتبت دكتور. مساء
تفضلي.
الخير جميعا، مساء الخير جميعا، وشكرا جزيلا
هلا.
دكتور على المحاضرة. Just I want your clinical opinion about the use of clozapine in non-well good response to other antipsychotic, and the real in clinical practice shorter time it takes you to switch to clozapine. And here in Iraq, sometimes there is a delay, unexplained delay for me, in fact, in using clozapine in clearly not well responding patient to other antipsychotic. So I want your clinical opinion about that. Thank you very much.
Thank you. Okay, Dr. Walid?
Okay.
Yeah, I think it's optimistic, to be honest with you, Doctora. Nowadays, we do switching and starting clozapine in the community within a short period of time. You know, previously we used to start with 12.5 once a day for a couple of days and then go into BD. And then after a few days, we increased the one at night.
The slow
50.
tapper of clozapine, yes.
Sorry?
Very slow tapper of clozapine to deal with the side effects, yes.
Nowadays, there is an encouragement to double the dose and to do it quicker. And you can do it, you don't need to admit the patient to inpatient service to do that. You can do it in the community because you are working with a team. And this team, they might be able to visit the patient at home and to monitor the vital signs, especially the blood
هناك
pressure.
هذا اللكشري دكتور في المنطقة العربية لا في هذا زيارة بالبيت ولا
ما في. طب شو اللي بمنع دكتور وليد؟ والله أنا
يعني لسه في خطوات كثيرة في عندنا تأخر في العمل الصحة النفسية والفريق، وإما العمل ضمن مستشفيات أو عيادات فردية على الأغلب. يعني مثلا كوميونيتي نيرس ما في، سايكاتريك نيرس ما في. الآن في سايكولوجيست إلى حد ما معقول، بس باقي الفريق مش موجود. لكن مع ذلك يعني أنا ما عمريش اشترطت بأنه الكلوزابين لازم يعطى inpatient. It's commonly إني أبدأ as outpatient. زي ما حكت الدكتورة جنان بيصير تأخير كثير، يعني بيجي المريض له 7 أو 8 سنوات not responding، بياخد very high doses. يعني I remember a patient بياخد كان 16 ملغرام ريسبيريدون، وبياخد أميسل برايد 1400، وبياخد كلوبكسول ديبو يعني أظن 400 بالأسبوع. And there was no response whatsoever. And that was going on for 5 years until I saw him and started clozapine. Dr. Jinan is saying is true in the region that يعني the psychiatrist ما بدهم headache الكلوزابين، واعمل فحص وارجع. خصوصا انه احنا ما بالغالب we don't cover catchment area. يعني عشان تتخيل my catchment area شو بتتوقع دكتور أمين؟ أنا my catchment area بتبدأ من بنغازي إلى أقصى شمال سوريا، إلى بغداد، البصرة، الكويت، الإمارات، قطر، البحرين، عمان، اليمن. فمن الصعب إنك في مريض جاي 3 أيام تعمل هذا الكلام.
صح.
لكن لو كان في نفس المنطقة أنا ما أعتقد في أي صعوبة. وحتى يعني التخوف الهائل ده من الأجرانيولوسايتوزز. يعني أنا على مدى سنين كم مريض شفته صار له مصيبة من الأجرانيولوسايتوزز؟ مريض واحد لم أكن أنا يعني طبيبه، لكن المريض لا عمره عمل وايت بلود كاونت، ولا عمره أخذ الكلوزابين، وخلص بياخده بدون ما يعمل أي فحص. وفي يوم صار عنده سيفير فيفر ونمونيا، وأدخل المستشفى ليكتشفوا إنه أعتقد كانت يعني الوايت بلاد كاونت عنده 1000 أو 900، و he died. بس يعني this is a very exception. برضه what we face in Arab countries إن الكومبلاينس عندنا كثير أضعف من ما هو يعني في يوكي. يعني في يوكي الناس بتحكي له، بتقول له اعمل فحص، وبيعملوا مع الجي بي، مش ضروري يرجع، وبيعملوا كل أسبوع وبوصلك إذا حبيت. العملية هون ما في، بده يرجع أول 16 أسبوع يعمل كل أسبوع يعني، وتيتريشن وارفع ونزل الأدوية الثانية. فهذا اللي بيأخر. أما يعني سبب علمي ما في، هو سبب لوجيستكس أكثر ما هو سبب علمي.
نعم. نرجع للدكتورة. بالنسبة لموضوع السويتشنج، تفضلتي حضرتك. هو بيعتمد على الدواء الأولاني إيش كان يعني، وكل الموضوع إنه بدك تعتبري الرياكشن لنيجروسترياتال component of the brain. يعني كيف لما انت تجيبي another antipsychotic، يعني بدناش احنا ننتهي في موضوع ال NMS Neuroleptic Malignant Syndrome، لأنه بصير يعني huge kind of blockade to the neurotransmitters. فإذا ممكن يعني مثلا الريسبريدون ولا الهالوبريدول you need to do it gradually over time، وبعدين started the clozapine. الموضوع
في
أسهل
سؤال برضه، في سؤال عن الكلوزابين، عن التيتريشن. دكتورة صفاء بتسأل يعني مش واضح إلها التيتريشن.
لا دكتور، أنا مش على التيتريشن، يعطيك العافية. هلا إحنا عنا عشان نصح الأدوية، فكتير في أطباء للأسف بيكتبوا كلوزابين جرعة 25 ملغ فور انسومنيا.
ما هذه المصرية القديمة في مصر
فهل
بيستعملوا
أنا
الكلوزابين من الستينات بدون فحص، وبيستعملوه للإنسومنيا كلامك صحيح سليم. يعني هذا يعتبر خارج إطار الكلوزابين نهائيا. الكواتيابين بجرعة مشابهة ممكن يؤدي إلى المطلوب بدون ما ندخل المريض في ريسك اوف ليكوبينيا ونيوتروبينيا علشان انسومنيا. يعني it's very accepted practice to use quetiapine 25, 50, even up to 100 in such patients.
Yeah, that's absolutely right. يعني there is no indication to use this small dose of clozapine for sleep يعني. No.
دكتورة صفية.
السلام عليكم.
السلام.
شكرا على المحاضرة القيمة. هي قبل التساؤل مداخلة، يعني لا يزال هذا المرض يعني المريض مصاب بسنوات وهو لا يعرف تشخيص مرضه، بسبب أن يعني قسم من الزملاء يخشى أن يعني يخبر المريض أنه you have schizophrenia، أو يعني ما يعرف هو مصير مرضه. والتساؤلات اللي يعني نواجهها من قبل العائلة، خاصة for the first episode what the fate of my son مثلا about his marriage, about his academic performance. يعني احنا احيانا يعني تكون صعبة على العائلة ان اخبرهم انه هذا مرض مزمن وانه راح يبقى على العلاج يعني ربما مدى الحياة. يعني مرات أنا أستخدم يعني سنوات طويلة، وأذكر مثل ما ذكر أستاذ الدكتور وليد أنه لا تزال أبحاث وأدوية جديدة وإلى آخره. يعني أحاول يعني rehabilitation. يعني عندي حالات طلبة في الكليات، نعم تواجه صعوبة بالدراسة بس يعني مستمرة. وعندي حالات من المرضى يعني they have hallucination and they retain their insight، يعني تجي وتخبرني أنه الصوت موجود لكن تحاول تقاوم. What new about psychotherapy for schizophrenia and whether يعني psychotherapy can minimize the doses of treatment or even if the patient have such side effect، أو يعني يذكر أنه أنا ممكن أقاوم الصوت أو لا أخضع له، لو يعني بكل الأحوال هي الميديكيشن must be. وشكرا جزيلا.
يعني أنا شخصيا يعني دائما أفضل الصراحة الكاملة. لا أقول كلمة مدى العمر لأني أنا لا أستطيع أن أتحدث عن الطب بعد 50 سنة لشاب عمره الآن 20، لكن أقول طويل الأمد ولا نعرف، لكن في المستقبل المنظور يجب أن يستمر، لأنه في الواقع عدم إخبار المريض وأهله يؤدي إلى مشكلة فقدان الثقة بالطبيب، والفقدان الثقة بأنه يصبح الموضوع صعب. يعني بعدها يعني يقول لك أنا حكيتي لي سنة صاروا سنتين 3، ما أنا معناه تارك العلاج، وممكن يكون سبب لانتكاسة كبيرة. فلا هي صدمة عند القول إنه هذا مرض طويل الأمد وعلاجه طويل الأمد، لكن هو الحقيقة. يعني تماما اللي عندهم سكري تحكي له هذا علاجه طويل الأمد وهذا سكري، برضو الناس بتزعل وفي ناس بترفض التشخيص وبتعتبر إنه يعني هذا تشخيص مش منطقي ومش مقبول، لكن بالنهاية بده يقبل بالأمر الواقع ويتعامل معه. في سؤال ثاني من الدكتورة بسام: هل يجب انتظار فترة 4 إلى 6 أسابيع قبل تغيير الأنتي سايكوتيك حتى لو لم يظهر المريض أي تحسن حتى ولو طفيف منذ البداية رغم مراجعة التشخيص؟
والله هو الأفضل إنه يعني withdraw the first drug gradually وبعدين started. If you are asking about clozapine.
How long would you wait for the first drug to
No, we don't need to wait. The important is the withdrawal of the first drug slowly, gradually, يعني over 4 to 6 weeks. But also
السؤال هذا كما يلي: هو هل دائما لازم ننتظر 4 إلى 6 أسابيع؟ طبعا هذا السؤال لأنه في كثير من المصادر تقول إنه if there is no effect whatsoever in 2 weeks it's unlikely this drug will work.
إحنا لما نحكي عن treatment resistant
لا ما أحكيش عن treatment resistant، نحكي
لا
عن
بشكل عام دكتور وليد.
بشكل عام.
بشكل عام لما نحكي عن treatment resistant to justify going from switching from first drug to a second drug, you need to give appropriate adequate time. And the adequate time in pharmacology, it's 4 to 6 weeks. So if I start somebody on risperidone, for example,
if it's first episode, would you wait 4 to 6 weeks or less?
يجب يعني if we need to identify the reason behind switching. يعني if you start somebody on risperidone, yeah, definitely you will start with a small dose, 2 milligram, and then you increase it to 3, 4, 5, 6, up to 8. Yeah, you need a minimum of 4 to 6 weeks. And then you switch to another one. Yeah. But there is something called cross-tapering. And let me explain. For example, and this is what I do, honestly. If somebody is on olanzapine and they have managed to get it to 20 milligram daily, and they don't show any significant improvement, yeah, I meet with them and their carers, and I explain the plan, which is cross-tapering. And that means that I reduce the olanzapine 20 to 15 for 1 week. 1 week. Meanwhile, I can start aripiprazole, for example, 5 milligram. The same day. I start the aripiprazole 5 milligram, reduce the olanzapine to 15, yeah, for 1 week, and the week after from 15 to 10, and I increase the aripiprazole to 10. I do that very often, especially with the drugs that I feel more confident with. Not clozapine, for example, yeah, but the drugs that I feel confident, olanzapine, aripiprazole, paliperidone, these kind of drugs you can do cross-tapering. Why I am confident? Because I work with a team who are in touch with the individual. So I know if they have any side effects or any complications of the process, they will let me know straight away. So I can see them quickly. Yeah, this is called cross-tapering. But if you want to get rid of the first drug and to start another one, I think you need 4 to 6 weeks. With the difficulties that you have in terms of having access to the individual.
دكتورة انشراح بتحكي عن السيلف دايجنوزس ADHD. الآن في عنا يعني باترن واضح صار، الناس كلها بتيجي على العيادة مع تشخيص. يعني بدخل على شو مالك؟ أنا عندي بانيك أتاكس، أنا عندي ADHD. بتطلعوا على جوجل، على الانستغرام، بطلع 3 4 أعراض، بشخص حاله، بنزل من جوجل واحد من الكويشنير بجاوبهم، بدخل معه تشخيصه. هلا هذه يعني ضريبة السوشيال ميديا، ضريبة باهظة، وكثير من الأحيان أنا بكون مضطر إني أقول نهائي لا تمسك السوشيال ميديا ولا جوجل، خصوصا مرضى الانكزايتي. هيدك بيروح بدور على أسباب الهيدك، أول من شيء بيطلع له برين تيوب، يعني بضيق نفسه بيروح بدور على ديسنيا، بيطلع له هارت فيلير، وبيطلع له فهذه مشكلة يومية بنواجهها. ومع الأسف يعني كثير من الأحيان حتى في بعض الناس بتحداني بأنه هو شاف باليوتيوب إلي بحكي عن الموضوع، فهو شخص حاله بناء على كلام. يعني
أيوة.
أنا اللي بحكيه على اليوتيوب عام، أنا بحكي لك شخصيا تشخيصه هو مش صحيح، وما بوافق.
نعم.
ما بوافق وبحتج بشدة وبزعل، وبروح يعني بيطلع زعلان لأنه ما يعني طلع تشخيصه غلط. بطل الموضوع أنه هو ممكن يتعالج ولا ما يتعالج، لازم يعني نتفق معه على التشخيص.
نعم.
تمام.
والله احنا مجتمعاتنا دكتور وليد يعني بتحس إنهم بيعرفوا كل شيء، يعني في السياسة
احنا
بيعرفوا كل شيء.
الشعب العربي عالم
آه في الدين.
بالطب والهندسة والطيران والسياسة كله.
بيعرفوا في كل شيء يعني هم. فلما تيجي تسأل واحد مثلا بدك تشتغل، شو بدك تشتغل؟ بقول لك والله أي شغل.
لا
أي شغل.
أي شغل.
فهاي الكلتشر اللي عندنا يعني هي سبب من هاي الأسباب اللي بتتفضل فيها حضرتك.
تفضلي دكتور انشراح. نسمعك. ما أوكي.
تسمعوني؟
يعني إحنا طولنا عليك اليوم دكتور أمين، شكرا
لا
جزيلا.
بالعكس، والله فرصة سعيدة، وخاصة لأهلنا في غزة يعني.
تسلم.
أنا سعيد
أنا
جدا أن أكون مع حضرتك ومع الزملاء يعني. وإذا في شيء آخر أنا مستعد، يعني إذا أي حد عنده سؤال كذا يعني بيعرفوا كيف يتصلوا معي.
سيكون لنا لقاءات متكررة إن شاء الله.
إن شاء الله.
شكرا جزيلا، تصبحون على خير، إلى اللقاء.
تسلم، شكرا، مع السلامة.